Institute of the United States. He has been the founding director of this institute, which is just alone a remarkable thing. And he is a multiple honored scientist with various honors he has received as well from his academy as from other places. He will speak on the global cervical cancer control. The Trimble, it's yours.
Thank you very much. I'm honored to be here. I want to thank Mr. Lin and the STUF Foundation, the organizers, for inviting me to join you. I've had the privilege of interacting with Taiwanese scientists for a number of years. My then boss, Dr. Harold Varmus, who is a Nobel Prize winner, and I were able to tour institutions in Taiwan several years ago, and certainly both Dr. Varmus and I were very impressed with Taiwan's commitment to biomedical research and to public health. In addition, we've worked with Dr. Chi-Jin Chen in his role as an expert on hepatitis B, as well as in his role as Vice President of Taiwan. Also work closely with Taiwan on health issues through APEC, and I've also been aware of the progress that Taiwan has made in biomedical research through the work of my father-in-law, Dr. Darrell Liu, who was director of the Institute of Biochemistry at Academica Sinica for 5 years. So today I wanted to talk a little bit about the global cervical cancer prevention and control, to discuss the history of how we have made progress, as well as some of the barriers that we are currently facing toward cervical cancer prevention and control. So with this picture, you see the current Director General of the World Health Assembly, Dr. Tedros, who in 2018 issued a call for a global initiative focused on cervical cancer prevention and control. And this encompasses vaccination against HPV, screening and treatment of both pre-invasive and invasive disease, as well as effective symptom management and palliative care. So I wanted to first review the history of how we have gotten to the point that we're able to call for a global initiative. This is a map that shows the world with the size of the countries modified somewhat for global population. And then when you, and this is a similar map, but you see the global burden of cervical cancer. And as you can see, it's particularly impressive in South Asia, East Asia, Africa, and very slow rates in Australia, for example, which has almost disappeared from the map. Cervical cancer is the third most common cancer among women. The latest reports from the International Agency for Research on Cancer are that there will be more than 600,000 new cases a year and almost 350,000 deaths, with a mortality to incidence ratio of greater than 50%. So if we look first at the history, you will see that we've developed progress first in symptom control, then beginning to understand the epidemiology, development of treatment more than 100 years ago, development of screening and treatment of pre-invasive disease almost 80 years ago, all before we understood the virology and the biology of the disease. Since we understand that, we've been able to develop interventions for primary prevention. So I date my historical perspective back to the 18th century or the early 19th century to this person, Friedrich Sertuner, who was a German scientist who was the first person to isolate morphine from opium in 1804. It was named after the Greek god of sleep, or Morpheus. And it was first sold by Merck in 1827. So by that time we had pain medicine effective pain medicine, and we still use this medicine frequently today for treatment of symptoms for cancer. Switching now to Verona, which is the home of Romeo and Juliet, one of the first epidemiologists, Domenica Rigoni Stern, evaluated the death records occurring in his city of Verona. And he noticed that breast cancer was more common among nuns than among laywomen, and that cervical cancer was more common among laywomen than nuns. It was also more common among commercial sex workers, leading him to conclude that there may be some association between sexual contact and cervical cancer. Progress for surgery was noted around 1900 with the developments of radical hysterectomy, which remains one of the standard surgical procedures, by doctors at Johns Hopkins and doctors in Vienna, particularly Dr. Schauter and Dr. Wertheim. The progress about the same time in radiology and radiation oncology began with the work of William Röntgen, who discovered X-rays, was awarded the first Nobel Prize in physics, and Marie Curie, who discovered radiation and the elements of radium and polonium. And she was one of the few people to receive 2 Nobel Prizes in 1903 and in 1911. And because of the developments in radiation, we were then able to begin to treat women with cervical cancer with both external beam radiation therapy and intracavitary radiation directly to the cervix. The next major development was by Dr. Papanikolaou, who was a cytopathologist originally from Greece, trained in Germany, but worked for many years at Cornell New York Hospital. And he was the first person to report that cervical cancer could be detected by a cytological smear, which we call the Pap smear. And this shows a normal Pap smear to your left, and you see very small nuclei. The cytoplasm is clear. And on the right is an abnormal Pap smear. And you see that the nuclear to cytoplasmic ratio is increased. The nuclei are very big. The cytoplasm is relatively small in comparison. I also want to give credit to his wife, who was worked in the same laboratory as her husband for decades, and to help him understand how a Pap smear changed over a woman's menstrual cycle, she agreed to undergo daily Pap smears for 20 years. So I think she deserves credit for that. So in addition, not only did we now have a potential screening test, but women were willing to undergo a speculum exam, which is painful and uncomfortable and embarrassing, but has resulted in us being able to reduce the incidence of cervical cancer. So we are now able to show what a normal cervix looks like, and that's the picture on the bottom. What a normal Pap smear is, that's on the top, and what a biopsy of the normal cervix is. When a woman gets infected with HPV, there are then changes in the Pap smear, changes in the cervix itself, and you see the photomicrograph at the bottom, and changes in the biopsy. This shows evidence of cervical intraepithelial neoplasia grade 3, or a precancerous lesion. And then finally, this is what a cervix with cancer would look like, both from a perspective of the the gross picture at the bottom, the biopsy in the center, and the pap smear on top on the right. So we've learned that we can treat pre-invasive disease by destroying or removing the abnormal cells. And this can be done through freezing, through thermal ablation, through a laser, through surgical removal. But we know that there are complications associated with that treatment. Certainly with the freezing and the burning, we don't have a specimen for pathology, and it doesn't seem to be as successful for adenocarcinoma in situ. With the excision, we know that there's increased risk of preterm labor and delivery, and an increased risk of infertility. And then with hysterectomy, there are the operative risks as well as with the loss of fertility. This is just some diagrams showing the surgical treatment of invasive disease, which can be done with a total hysterectomy, partial hysterectomy, or radical hysterectomy. We've also, this is just a picture of a woman undergoing radiotherapy for the invasive disease, which we've learned that needs to be combined with the internal brachytherapy for effective treatment of, and generally curative treatment for invasive cervical cancer. So we had all that treatment and the screening before we understood that the disease was caused by a virus, the human papillomavirus. And this is a picture of Harald Zerhausen, who was a German scientist working at the German NCI in Heidelberg, receiving the Nobel Prize for his work. So it was in 1976 that he first reported finding HPV in genital warts and in cervical cancer. And he went on to identify that there was a family of more than 100 papillomaviruses, which can infect skin or mucous membranes in mammals. That he identified that there were certain subtypes associated with cancer, particularly 16 and 18, and that the E6 protein blocks the normal cellular control mechanism of P53, and the E7 protein blocks the normal retinoblastoma cellular control mechanism. Because of this discovery, we were then able to identify that HPV causes a number of other cancers, including anal, vaginal, some penile cancers, some cancers of the oropharynx, and that we were able to better understand the incidence of cancers attributable to infectious agents. And you see that we know that infectious agents, in this case Helicobacter pylori, causes stomach cancer, HPV causing cervical cancer, hepatitis B and C, liver cancer, and then EBV causing nasopharyngeal cancer. So because we understood the etiology, because of the human papillomavirus, we were then able to work on primary prevention. And 4 academic laboratories worked to develop the prophylactic HPV vaccines. The leading, the core work was done by the National Cancer Institute and the University of Queensland, but together these 4 laboratories signed a non-exclusive license to Merck and to Glaxo for the development of these vaccines. So this is a picture of John Zhao and Ian Fraser at the University of Queensland, who led the work there. And these are my colleagues at the USNCI, Drs. Lowy and Schiller, who led the work at the USNCI. So this is just a schematic of the prophylactic HPV vaccine. It's an empty viral capsid, and the very effective. There are now 3 products on the market: Gardasil, Gardasil 9, Cervarix, as well as more recently generic equivalents being made by 2 companies in China and the Serum Institute in India. It was approved by the FDA in 2006, It's recommended in the U.S. for boys and girls. It's recommended by WHO SAGE as well as the Gavi. So now, in terms of cervical cancer control, we can do primary prevention through the vaccine. We can do secondary prevention through screening. We have treatment that I mentioned, surgery, radiation, and we have palliative care. But we still have problems. You saw the statistics for the world. One of the problems has been that pap smear screening is expensive and cumbersome. It requires recurrent visits, referrals to specialists. You need to train cytotechnicians, cytopathologists, colposcopists, gynecologists, as well as have very strong quality control at all levels. In addition, we've learned that there are system failures leading to cervical cancer diagnosis. This is kind of the so-called Swiss cheese model, where first it could be that a woman does not come in for screening, or that the healthcare provider doesn't offer screening when the woman comes in, or that the colposcopy following an abnormal screen is not done, or the patient doesn't get the appropriate therapy after evaluation, and as a result, the patient gets cervical cancer. So it's particularly important that we address those system issues when we set up screening programs. There have been some efforts to develop alternative screening approaches using visual inspection, either with acetic acid or something called Lugol's solution, which can be done by trained nurses and community health workers. The challenge there is that it really needs a ongoing evaluation and training because the images with visual inspection are not as clear-cut as we would like. We are now looking at HPV diagnostics, which look much more promising. They were first promoted as an adjunct to pap smears, but now replacing pap smears. And more recently, a number of centers around the world are now moving towards self-collection of HPV, where a woman swabs her own vagina rather than undergoing a painful speculum exam. And in the United States, the US FDA has recently approved self-collection about 2 weeks ago. The challenges for HPV testing, though, are the cost. It is still in the developing world, the prices are in the range of $20 to $50 per test, although in Western Europe, where there's more competition, the cost of an HPV test is lower, around $6 to $7. One does need a central laboratory for the least expensive tests. We hope that the point-of-care tests will be more available at a good price, but currently we do not have that. There has been an effort to look at what's called automated visual evaluation, or using AI to evaluate the cervix, but that has not been validated yet as an approach. A number of groups are looking at it, but it is promising, but I would not recommend it as a standard procedure at this point. What we've also observed in terms of treatment of invasive disease is that in many countries, universal health care may not cover screening, may not cover cancer, may not cover cervical cancer. So we know that we need to be working with countries around the world to encourage them, as they ramp up universal health care, to include coverage for screening and cancer care. Cervical cancer disproportionately affects poor women in rural settings, and we know that these women often need help with patient navigation, help with transportation, help with lodging, help with social support. We need to make sure that we increase access to surgery, to radiation therapy, to chemotherapy, to immunotherapy. We increase access to good symptom management and good palliative care, as well as to strengthen health systems so that we have the informatics in place to track women, to see who's been screened, to make sure that a woman who has an abnormal screen gets the appropriate follow-up, to make sure that no one is lost to follow-up, as in that Swiss cheese diagram I showed you, and to make sure that the appropriate medical imaging, diagnostics, pathology, and other laboratory services are in place. Symptom management is also critical. We've learned a lot about how best to do this, but the most recent reports coming out of the WHO show the degree of distress and pain and symptoms associated with invasive cancer. Intimacy is a major issue. The data coming out of WHO suggested that almost 40% of women are deserted by their partner after a diagnosis of cervical cancer. We need to make sure that we, whether it's surgery or radiation or combination, that we try to preserve sexual, bladder, and rectal function. We know that fatigue is often a symptom associated with cancer treatment. We have interventions for that, but we need to actually talk to patients and see how we can address them. And then we need to help women who are cured of their disease return to normal family life and work. And then for those people whose disease recurs or their disease is not curable, we need to make sure that effective palliative care is in place. We know how to do that. As I said, we've had morphine since 1804, and we have designed a portfolio of interventions that can help a woman maintain her dignity in the face of progressive cervical cancer, but that needs to be in place. So going back to the call to action, this was something, as I said, that Dr. Tedros called for in 2018. Subsequently, the staff at the World Health Organization worked with countries around the world to put together a strategic plan that includes vaccination, includes screening, includes treatment, and includes symptom management. As I mentioned, they did a major effort on symptoms and published 3 papers on the unmet needs as well as interventions for symptom management. We are working with other UN agencies, including the UN Family Planning Agency, including UN Women, including UNICEF, which is very active in vaccines, as well as with the International Atomic Energy Agency, which in the UN system is responsible for medical imaging and radiation therapy to help improve access to all the interventions that are necessary for cervical cancer prevention and control. So I'd be happy to answer any questions. I have to run back to the World Health Assembly and my duties on behalf of the U.S. government. So.
Thank you very much for a very clear and understandable and I think comprehensive overview of the field of your work. You are here at the World Health Assembly quite obviously demonstrating that your interest in science doesn't end at the doors of your institute and not at the realm of scientific conferences. Since you have to leave us now, may I ask you one question? If you had a wish to this global community of global health, what would be your priority? What would you tell them to do in order to improve the situation in prevention and management of cancer?
Well, that's I'm not sure I can come up with a one-word answer to
You can
that
have several wishes, of course.
Yes. Okay. Well, I think in terms of we've learned a lot about how or the intersection of risk factors for cancer and other diseases. So I think certainly Tobacco control is critical because we know that that affects the risk of chronic lung disease, heart disease, as well as a number of cancers. We've learned about the importance of healthy diet and exercise because, again, that affects cardiovascular health, metabolic health, as well as risk of cancer. And we've learned a lot about the importance of controlling infectious diseases. I mean, in the cancer space, you saw the data from, but we have now vaccines for HPV and hepatitis B. We have treatment for hepatitis C, so we want to make sure that we treat infections that can lead to that can lead to cancer. So I mean, I think in terms of my priorities, in terms of would be to try to prevent as many cancers as possible. And secondly, to improve the systems to make sure that cancers are diagnosed early, patients have the best possible chance of treatment, of curative treatment, and then that we manage an individual's symptoms as well. So.
Thank you very much. Well, let's give an applause to Dr. Trimble and thank him for being with us this morning. Thank you very much.